One of the big problems of PD-L1 expression is the inherent heterogeneity of its expression across a tumour, both in terms of space and in terms of time. But this isn't a surprising feature of it because we know that tumours do look different and we know that tumours are genetically diverse across their environment. And this is an obvious problem when it comes to sampling. The question then is how much does this vary between the primary tumour and metastatic deposits? And we see that there can be quite a lot of variation between this, as much as 50% in terms of any difference, maybe as much as a quarter of cases might be changed in terms of that clinical cutoff. And there remains this question then that it possibly depends on the indication. So at the moment, PD-L1 therapy is not really given in the adjuvant setting, and it's not really given in cases that are looking at curative attempt. But there may be a shift in the dynamic, and so we may say to ourselves, okay, right now, if the primary amount of tumour burden is a primary tumour in the lung, then we might want to take samples from that tumour to give us a more representative idea of what that PD-L1 expression is doing. Whereas in an adjuvant setting, if most of the tumour or all of the tumour has been resected, you would clearly want to know what the metastatic deposits are doing in terms of the PD-L1 expression. And so that variation becomes a very important point. And I'd also just like to mention that we're also starting to gather data that not all samples are equal in terms of providing of PD-L1 expression, and there's a question mark over things like pleural fluid, and now it's possibly giving us a higher false positive rate than we would really like. So it's a constantly evolving area in terms of what we can look at, when we should look at it, and what the most appropriate uses of PD-L1 immunohistochemistry is.